pregnant with much less than 60 million sperm per cc. But
it takes only one, as a matter of fact.
Takes only one.
It's not likely, though, that there would be an ejaculate with one sperm.
Well, no, that's one. There are many problems. Men have a range of sperm counts that go from 0 to 150 million. And it's true that the higher the sperm count, the easier it is for the wife to get pregnant. So in these banks, they would reject anybody with sperm counts of less than 60 million. Well, they used to have to reject only 25% or 30% of their prospective donors. And it's a consistent observation now that they have to reject about 80% of their donors now.
Maybe this is God's way of telling us we're having too many kids. What I mean to say is...
So it seems that the sperm count, at least from the studies in Europe, we don't have large-scale studies in the U.S., would indicate from several different centers that the sperm count is diminishing.
But could there be a Darwinian explanation for this? I mean, maybe this is just too complicated an attempt to understand this, but...
you know, the human male really is reproductively very inefficient anyway. If you were to look at a...
Easy, doctor. Easy. Oh, you're going to applaud that, too? I am extremely disappointed in this audience.
If you look...
Because it takes a lot of fodder to make... No, I got two jokes there.
Right.
In other words, it takes a lot of sperm to effect one impregnation.
Right, it's just a statistical chance. If you only have a small number of sperm, then the chance of just one of those sperm reaching the egg and as we say, cracking the egg is very low. But it does happen. But if you have a huge army of sperm, 60 million, the greater the number, then just statistically, in any given month, then the greater is the chance of pregnancy occurring. It's purely a statistical relationship. And if you look at the testicle biopsy, the architecture of the human testicle, you compare it to any other animal, you'll be amazed, because even a layman could look at it and there's a very regular, beautiful architecture to almost any animal's testicle. I mean, whether it's the dog or the rat. But when you look at the human testicle, the stages of sperm production are chaotically mixed up in a very chaotic mosaic pattern. And so from a Darwinian point of view, though I wasn't going to emphasize this, it does appear that reproductively we just are on the bottom of the reproductive scale in terms of efficiency. As
our grandfathers had more efficient testicles than we did, is what you're saying. But that is what you're saying. I don't want to just be cute here. That's a fact you're saying.
Right. I don't understand why it seems that the sperm count is diminishing just over a short period of time, like 10 years. But we know that over millions of years, comparing humans to other animals, there is a clear-cut architectural chaos in our testicles compared to other animals.
We have... you also say that it's apparently becoming more clear or more possible that male stress can diminish sperm count.
Right. Unfortunately...
So when the guy's about to be laid off, he's not going to be able to have a baby.
Well...
or at least the hypothalamus. Well, tell him about that.
Well, in both males and females, there's a primitive region of the brain called the hypothalamus. It sits right at the bottom of the brain, right next to the pituitary gland. And it releases a substance called GnRH, very simple substance, actually. The Nobel Prize was awarded in 1971 for really discovering this substance. It's released from the brain. It goes right to the pituitary gland, and it stimulates the pituitary's release of the hormones that in the male cause you to make sperm, and in the female cause an egg to develop and to ovulate.
Is that testosterone?
No, it's GnRH is this substance. It goes from the brain to the pituitary, and it makes the pituitary release what's called FSH and LH. And in the male, the FSH and LH cause us to make testosterone and sperm. In the female, the FSH and LH, which comes from the pituitary, causes her to ovulate. And we've known for a long time that anxiety and stress can totally wreck ovulation. We have thousands of clinical examples of how stress and anxiety in the female interfere with ovulation. It's a well-known observed fact. And in fact, that may be one of the very many reasons why we have an infertility epidemic right now, that under the tremendous stress of modern life, there is a fantastic amount of poor ovulation in the female population.
You know what else seems to support that thesis? You ever notice often when an infertile couple who've tried all those years adopt a baby, they have their own baby. So adopting the baby, the pressure's off, you relax, and you get pregnant.
Right, and bringing this issue up can really sometimes can irritate infertile couples, because these are people under terrible stress for 5, maybe 2 years, 5 years, 10 years, and the last thing that's going to do any good is to say, oh, well, you're just a little too nervous, why don't you relax and take a vacation? That's like telling an insomniac to stop thinking about why you can't fall asleep. And I found that all that you can do to relieve the stress and anxiety, which is one of the major culprits, is to educate the layman, educate these people about what's happening reproductively. In other words, why their egg isn't developing, what will make it develop, how the sperm meet the egg, the entire process of getting pregnant. Once they understand it, they feel they have a sort of a grip on the situation, and we have so many cases where it's just incredible to see a flat ovulation curve, no ovulation, and all of a sudden the wife starts ovulating once their anxiety has been relieved by knowledge. And sometimes with terribly low, miserable sperm counts, the wife gets pregnant shortly after they learn more about the whole process.
I'd like to show you, we've seen this film before on this program, but it's as revealing a brief piece of film as you can possibly imagine. Maybe I shouldn't impose my own awe at this on you. And I can't help but think what a good idea it would be, this is my opinion, to show every freshman in high school this film, especially the boys. What you are about to see is a microscopic film recording of the sperm activity in just one ejaculate. And if you believe that...
right, now here you can see very healthy sperm that are moving at a rapid rate in a straight line. This is a fertile specimen. These sperm, now here you see one fertile sperm in a sea of terrible sperm, and it's moving in a straight line fairly well, but all of its brothers are very inadequate, and their motion will not be adequate to get into the wife, penetrate her mucus, or penetrate the egg.
There's sisters in there too, right?
That's right.
Okay.
Oh, God, sexism comes out.
Well, but I mean, the X and Y are there. Right?
These are X and Y. But you see, this is a terrible infertile specimen. Here is a sperm that's moving well but has no head, and this won't be able to get anybody pregnant. And right next to him, you just saw a fertile sperm. So in most infertile men, that is men with terrible sperm samples that the doctor says, forget it, you know, you'll never get your wife pregnant, in most of them there are a few fertile sperm. And if you can maximize the fertility of the wife, even in a miserable specimen like this, for example, here's a sperm that is abnormal, he's got a thick neck, and you saw moving right by him was one lone healthy sperm.
This one needs some help too, right?
This one needs a lot of help.
Yeah.
So the point is that you don't give up because the husband has a terrible sperm count. You do whatever you can to maximize the fertility of the wife, because infertility is usually a combination of problems in the couple and is not usually just ascribable to the man or the woman being infertile.
So when you look through your microscope, then you're looking for two things. You're looking for the count, and you're looking for what you call motility, meaning vitality, huh?
Right.
The vigor of the sperm.
Right, and also the structure of the sperm. But the structure, if the structure is good, the motility is good.
Yeah. And the sperm head, the head, rotates 360 degrees.
You see, in order for it to go in a straight line...
I mean, this is a piece of mechanical engineering, this thing.
It's an incredible piece of ballistics, that's right. Just like an arrow would never go in a straight line if it doesn't spiral, or a football pass wouldn't go very well if it doesn't spiral. The sperm can't go in a straight line unless the head is rotating.
But when you, if you know that, if you're an adolescent struggling with whether or not girls like you and all of the things that adolescent males, with the experience with which I am more familiar, go through, it seems to me that to know that is to promote responsible behavior. I think to take the mystery out of reproductive biology, to know that one ejaculate contains that many, and the sperm is hardly ever in this young man's lifetime more vital and active than it is at age 17, 18 years old, those days were, and then throw in the drive-in theater and the back seat of the car.
Right. I think the teenagers need to realize that they are at their most fertile stage of life. A 19-year-old gal with a 19-year-old boy have about a 35% chance per month of getting pregnant with unprotected intercourse, but a woman who's 39 has about an 8% chance without any other factors involved.
Do you want to briefly, can we go through this because we've got an audience here that has a lot of questions.
Okay. Sure.
Is this all right first?
Sure, right.
Let me put this over here. We going to be able to see this, Ronnie? Are we curveballing everybody here?
This is just...
All right, we're not pretending that you haven't seen this before, but let's just one more time go through this. Go ahead.
Okay, this is just an outline of the female genitals, and you see the ovary sits loosely in the abdomen. It's not attached to the tube, and the tube has to actively grab the egg when it's released from the ovary at the time of ovulation.
So an action takes place in the tube?
Right, this thing comes to life just before ovulation. It looks dead the rest of the time, but just prior to ovulation, it's like an octopus tentacle, and it literally has to grab that egg in order for the egg to reach the tube, and that's where it's going to be fertilized.
But the squigglies we saw, squiggly being a medical term I picked up, the squigglies we saw actually meet the egg in the inside.
That's right. The sperm are deposited here at the time of intercourse, and they have to march up a very long way through the uterus, get through what we call the uterotubal junction, and they meet the egg there, and that's where fertilization takes place. And the baby, all of us spent the first 2 or 3 days of our life right here in our mother's fallopian tube, and then when we're ready, we're transferred dramatically into the uterus, because then we're ready to implant.
And when the impregnated egg fails to make its way down the fallopian tube, that's called an ectopic pregnancy, and that is a very serious condition.
Right, and it requires emergency surgery usually to remove it.
Okay.
Right.
Now
this is just a closer view of what the ovary looks like. Now, we have found that there are a lot of so-called mysteries of infertility, and we have found now, looking at the couple approach, comparing sperm count and ovulation, endometriosis, a lot of other factors, that the most common problem, the most common reason for the infertility, the common denominator, is poor ovulation. And this is what happens. You start out with a little egg that has no follicle, and all we're going to ever ovulate, or the women are going to ovulate, is 400 eggs in their lifetime, and that's what they have when they're born, basically. They're not making any new eggs, and when they run out, then it's over. That's when they no longer can have children. And that, each month, another one of those eggs develops into a follicle, and then it's released and grabbed by the tube. Now, if this follicle doesn't develop properly, the egg may be released, but it's not mature and ready for fertilization, or if the hormonal milieu isn't right, the egg may not even be released. And it's this faulty ovulation that seems to be the most common overlooked reason why people aren't getting pregnant, even when the sperm count's miserable.
Yeah, well, how do you fix that?
There are drugs available that work. There are the simple drugs that are given out very, very readily, such as Clomid, that are simply pills. But then there are more complicated drugs that have to be given, like injections.
Right. I think you have some grievances, though, with traditional infertility counseling, which knee-jerk automatically hands out Clomid to people who don't need it.
Right. We have been very impressed about how you can look at a flat temperature chart and see that for all these years a woman has not been ovulating properly, the diagnosis has not been made, but as soon as they begin to understand the reproductive process, many of these women, a minority, but many of these women spontaneously start ovulating normally without any medical interference, and they get pregnant.
All right, we've got an audience waiting, so let's go.
Okay, there's only one. Even human women also are reproductively inefficient compared to the rest of the animal kingdom.
That's reassuring, Doctor. Thank you.
And at all times during the month, except just prior to ovulation, the mucus of the woman is not going to allow the sperm to get in, and the cervical opening is very tiny. When the doctor looks through the speculum, he sees a tiny cervical opening and poor mucus that's very sticky. The sperm won't get through.
Excuse me, but I know I'm contradicting myself here. I'm telling you we've got to go, and then I'm asking you questions. I don't understand. If the egg can't be impregnated until it's ovulated, what do you need the mucus for? What's the evolutionary reason for the mucus? Why would the body not want the sperm to get in there?
Oh, for the rest of the time. Well, probably because the mucus also keeps everything else out, such as bacteria. It would be wise not to have an open portal during the entire month.
Okay. All right.
So it just opens up when it's ready.
So, all right. So we keep the oven clean until we're ready to bake a cake. See, these little metaphors help us understand, Dr.
I understand.
All right, we're ready. Go ahead.
And just prior to ovulation, when the follicle is ready to release the egg and a lot of estrogen is being made, the cervix, the opening to the uterus, opens up dramatically. It dilates, the mucus pours out, it becomes very thin and watery, and is willing to accept the sperm only at that time.
And the mucus then dissipates or allows the entry of sperm at the moment of ovulation, before ovulation?
For about 2 days prior to ovulation. Now, once ovulation has occurred, it's probably too late, because then very quickly the cervix closes in response to the different hormonal milieu caused by the ovulation. The mucus becomes sticky, the sperm can't get in, and the egg only lives for about 8 hours after it's ovulated.
So it sounds like pregnancy is the result of ovulation taking place shortly after the sperm has already made its way toward the fallopian tube area.
That's right. The sperm have to be on their way ready and waiting, because the sperm will last for 2 or 3 days, and the egg won't.
So couples suffering from infertility should know that the best time for intercourse is just in advance of ovulation.
That's right. And many couples are infertile because they don't realize they're practicing rhythm birth control. They wait for their temperature to go up when they're going to ovulate, when they're ovulating, and then they have intercourse. And of course, that's just the Billings method of birth control.
I know. One more time. The sperm lives for how long in the fallopian tube area?
About 2 or 3 days. It's continually in the cervical mucus, sending up new platoons up into the fallopian tube over a 2 or 3 day interval.
And the egg survives for about?
8 hours.
We're with Sherman Silber, whose book is titled, MD, whose book is titled How to Get Pregnant. And we hope you'll join us.
I'm concerned with the abnormal sperm that I saw. If that impregnates the egg, will that cause an abnormal child?
No, it will not. I've had some patients make funny comments and say, if my sperm is like that, does that mean my kid will have to wear glasses? But no, it really won't be. The sperm that penetrate the egg and result in a pregnancy are the good sperm. The other ones won't make it.
What about the guy with the large testicle and the guy with the small testicle?
Does that have anything to do with sperm production?
Generally, it doesn't. Now, men with small testicles, if you average them out, are going to have lower sperm counts than men with large testicles. But men with large testicles could have a lot of sperm precursors, and in the final stage of sperm production, which is the most difficult, it's called meiosis, they're not doing it. It's called maturation arrest. They may have large testicles, but very low sperm counts. So testicle size really is a very poor indicator of fertility.
My question is to Dr. Silverman. Phil made a good point. Do you personally advocate teaching in school? I'm recently doing a project on book censorship and film censorship in high schools. And a lot of people are banning dictionaries from high schools that contain the word bed as a verb and a noun. And I want to know what your personal feelings are. Should these films be seen by freshmen, which, you know, I agree with, but I want to know your personal opinion.
Well, I guess it's a social issue outside of my area of expertise. But I think that if at any age, if knowledge is transmitted sensitively to children, it results in responsible behavior. If knowledge is if there are irresponsible statements made that are biologically untrue, which I think is a risk people are worried about, then it's bad. You've got to get good information, reliable information out to everybody, all ages.
I'd like to ask you about test tube babies. Is that really an answer for infertile couples?
Well, I'm glad you brought that up. The test tube baby issue it's extremely exciting biologically. We're learning so much from it. But it's really only an answer to a very small fragment of infertile couples, maybe 2%. And what I find very sad is that very often women who have clear-cut ovulatory dysfunction, which can be treated readily with the drugs that are available, and fairly inexpensively, instead are waiting in line to see whether or not they can have test tube babies, because they don't have a concept of what that's all about. The idea of the test tube baby is if your tubes are totally destroyed, such that microsurgery can't successfully put them together, this is a way of retrieving the egg from your ovary, fertilizing it outside the body, and then immediately putting it right back into the uterus within 2 days. It's a way of crossing a bridge that's been totally destroyed. But most women with blocked tubes can have that problem successfully fixed with microsurgery. That's number one. And furthermore, most of the cases of infertility are from ovulatory dysfunction. One of the most dramatic cases that I've seen was a woman she was the wife of a doctor, and she had terribly bad tubes. She had 2 unsuccessful microsurgical procedures performed elsewhere. She was referred to us for microsurgery. We looked into the case, and we turned her down. We said, look, this just is too difficult. It's too bad. Badly destroyed a tube, but you're going to have to go the in vitro fertilization route. You're one of those 2% that's just going to have that. But also, we've noticed your ovulation isn't very good, and that ought to be paid attention to. So her local doctor, was in a small community thousands of miles from St. Louis, decided to treat her ovulation, and we got a call from her about 3 months later. And I said, gee, I just want to tell you again that we really can't operate on your kind of case. Please, don't pressure me. She says, you don't understand. I called to tell you that I'm pregnant. Without in vitro fertilization, with terrible-looking tubes, but her ovulation was treated.
If a lady been taking birth control pills for 7 years and she decided to get off of them, how long would it take her to get pregnant?
Well, it really varies tremendously. Some women will take a year before their ovulation resumes. Some women it resumes right away. There are some women that the ovulation never resumes, and she may very well need treatment to get her ovulation going again.
But is there anything causal about the discontinuation of birth control of the anovulin pill and either higher or lower probability?
I don't think we have the proper statistical studies to make that statement. If you ask any gynecologists, they'll routinely say that birth control pills do not cause infertility except in women that were infertile before they started them. But we don't have good statistical evidence. There is a possibility it may hurt subsequent fertility in women who had irregular periods and who had some tendency towards ovulatory problems before they ever went on the pill.
Yeah, and if you can give a woman,
may be harmful.
If you give a woman a pill which in a hormonal way can suppress ovulation, and that's what the pill does through the pituitary, I assume, and all that. Okay.
Exactly.
You also can give her a pill which will enhance ovulation, or which at least allows you to isolate the time when the egg pops out.
Right, or just to enhance ovulation. If her temperature goes up, if she ovulates, say, day 19 or 20 or 23, very often doctors tell them, well, you're ovulating. There's nothing wrong with you. But that is wrong, because a fertile cycle is a cycle in which that follicle is matured and ready to bust by day 13 or 14, and you ovulate on day 13 or 14. And if you ovulate on day 20, that's not a good ovulation.
And if the hypothalamus has the same impact on the male reproductive biology here, drama, why don't we have a pill which will either enhance or suppress male sperm production?
Boy, that is a mystery. We have just recently studied that in great detail, comparing the wife's fertility with the husband's sperm count, and we have good drugs for increasing the man's pituitary secretion, but for some reason or other, only 20% of the time does his sperm count go up. And in those cases, we find that in that large group of men with low sperm counts, the most successful way of treating the low sperm count is by improving the wife's ovulation. 78% of men with sperm counts between 5 million and 20 million, which is considered low, the wife has poor ovulation. And if you treat it, you may enhance the chance for pregnancy.
If you treat the wife's ovulation with a drug, what are the chances of multiple birth? I mean, with this.
With Clomid, the chances are very low. That's why we're so happy to give it. But it's not that powerful a drug. It may work in 40% of cases at most. Pergonal is a cannon of a drug, and it will make almost every woman ovulate. But it's got to be monitored properly to prevent multiple births. But with modern monitoring, we call it rapid estrogen assays, blood tests, and with ultrasound to see how many follicles are actually there. With modern monitoring, Pergonal is very safe. There should be a very low incidence of triplets at least.
Getting over to our side, what about injury in athletic participation? specifically in youngsters, how does it affect them later on in life when they injure their testicles?
Well, we
Or
see.
does the parent even look into that?
Well, I wouldn't
part of
look
it?
into it. You'll set up a tremendous amount of anxiety about it, which isn't necessary most of the time. There are occasional cases we've seen where there has been epididymal blockage in men, young men, and we've had to do 25-year-old men who have been unable to get their wives pregnant, who had no sperm in the ejaculate. We've done some very, very incredibly delicate microsurgery to restore the epididymal continuity. This duct is about one 1/300th of an inch in diameter and 1,000th of an inch in wall thickness, very delicate, and we've reconnected them. And the only thing we could get in the history that was meaningful was an athletic injury, and so there are some cases like that.
Also, is it possible that the popularity of the jockey short could be related to diminished sperm count?
I don't think so. The reason that this became so popularly advertised in all the little articles you read here and there is that, you see, the testicle needs to be 4 degrees lower in temperature than the rest of the body in order to work. If we've had cases of adolescents or of 20-year-old men with no sperm production because the testicles were in their abdomen. We brought them down into the scrotum where it was 4 degrees lower, and sperm production over a period of a year to year and a half returned to normal. And we are sure now that just even a 2 or 3 degree temperature change can adversely affect sperm production. So the issue is, can tight underwear lower the sperm count? Well, we have studied this and having men wearing looser underwear, and we haven't seen any change. So what I think is that temperature regulating...
But it's not a foolish question, though.
It's
if there's a reason that
question.
All right, I'm being a little defensive here with it. There's a reason that the manufacturing area of the sperm, manufacturing area of the male, is outside the body.
Oh, absolutely.
And if you bring it in toward the body, you raise the temperature, and it sounds like you would.
Right, except that it seems like the tight shorts are not able to raise the testicular temperature. We think they could, we think they should, but they're not. They're not doing it.
And we'll be back in just a moment.
What about nutrition? Does that affect the sperm count? I've always heard things like buttermilk, increases a man's sperm count and things like that.
It hasn't been studied adequately, but most of the nutritional points are really not true. Most of these issues about nutrition don't affect the sperm count. There may be some unstudied that will, but we haven't seen any change.
Doctor, if a person is fertile, is there any truth to these rumors that you can pick the sex of your child?
No, there's no truth to it whatsoever. It's been highly advertised because the X sperm and the Y sperm swim at different rates and different molecular densities, but really it has been unsuccessful. It's been sort of lying with statistics.
But there are people out there who are putting the sperm in a vial, a medium solution, that they claim brings the male sperm to the bottom of the test tube, allowing collection and higher probability.
There have been a lot of claims, but whenever they've done enough patients to get statistically meaningful statements, it's always that you're 50% successful, and the ones you're successful with become great advocates, and the 50% that fail shrug their shoulders.
Are there any truth to vitamins, that vitamins, iron, and things like that would help impregnate a woman?
No, there is no truth to it, and I think we've really got to do away with all these witchcraft-like remedies, sometimes testosterone and all kinds of drugs that are used to try to raise the man's sperm count, and all kinds of crazy treatments to try to make the wife fertile. I've just heard one woman in the audience tell me that she's allergic to her husband's sperm. That is very, very rare. I mean, no, doctors are telling patients this.
Well, there's only so many. There's only so many times you can tell them you have a headache, you know. All right, we shouldn't be.
We wondered now, would douching prior to intercourse give the sperm a better chance?
No, it wouldn't. The idea is that the acid environment of the vagina kills the sperm. No, the alkaline environment of his semen protects him from your acid vagina, and any of the sperm motile enough to get into the cervical mucus will be protected by the alkaline environment of the mucus. So no, douching will just be one of those many things before intercourse that will cause more anxiety and make you less likely to ovulate, And if there's one thing I can emphasize on this show, don't forget ovulation. It is the #1 cause of women not getting pregnant. I don't care how low the man's sperm count is.
Doctor, you mentioned earlier that older a woman gets, her fertility drops. If I wait to start a family until I'm in my mid-30s, what are my chances of getting pregnant?
Well, if there are no other medical problems, women in their mid-30s have about a 10% chance per month of getting pregnant if there are no other problems and the husband's sperm count is normal, whereas in your early 20s it's about 30%.
Why?
Well, it appears, and there are a lot of speculations, the most reasonable explanation is that the most easily fertilizable eggs, the ones that are most responsive to the FSH stimulation in the first 14 days, are the ones that come out earliest. And you run out of eggs when you're in your mid-40s and go through menopause, and the most fertilizable ones come out earliest. Also, during
now, is it about fertilizability or is it about ovulation?
Well, the quality of ovulation is a general term, which relates to the fact that women whose follicles burst on day 14, whose estrogen rises just prior to day 14, and then have a 14-day, what we call luteal phase after that, are women who get pregnant easily. Women whose follicles burst later on, whose follicles develop over a 20-day period of time, are less likely to get pregnant. We refer to that as quality of ovulation, but really it's a matter of how well that egg is being matured prior to ovulation for fertilization.
And the older a woman gets, the more elongated becomes the process of follicleization?
Well, not always, but if you look at it statistically, that kind of pattern intervenes in a large number.
And we'll be back in just a moment. This book is titled How to Get Pregnant. You may wonder about that title in an age when so many people are trying not to. Dr. Silber and others who've been on our show want you to know that the issue of infertility is a very, very widespread, pervasive problem in our culture. And on more than one occasion, a person has come up to me and said, enough with the contraception, let's help the folks who are trying to have children. And there can be no more personal human drama than that.
What causes painful ovulation? And what about the months like that I got pregnant? I didn't have any pain that month, but there's pain on one or the other sides on the 18th or 19th day every month.
Well, painful ovulation is not anything we consider to be abnormal, but the fact that you have it on the 18th or 19th day indicated that those particular ovulations were not very fertilizable. I mean, they might have gotten you pregnant, but they're less likely to. A 14-day or a 15-day ovulation is the most likely to get you pregnant.
What about alcohol?
Alcohol can lower the testosterone level in men, and it can interfere with potency. We don't have any good studies on what it does to fertility.
How about pot, marijuana?
Oh, there have been a lot of conflicting studies going each way. As I try to synthesize all those studies, I don't see any good evidence for it causing infertility problems, though some would disagree with that violently.
Are all these malfunctions, are any of them hereditary? Can they be?
Well, some of these things are hereditary. That's right. You may wonder, how can you inherit infertility? But you can. Typically, women that don't ovulate well and need to be treated have mothers that had a very difficult time getting pregnant themselves, 10 years in between children.
A varicose vein in the testicle area can diminish sperm production, true?
Right. And unfortunately, because this is very exciting, that a small number of men will have too warm a testicle because of this varicose vein allowing blood to drip down. But unfortunately, almost every man that I've ever heard of having a low sperm count is told, they come to me for second opinions, has been told that he has a varicocele and needs a varicocele operation. I have to point out 15% of all normal men have varicoceles. If the men in this audience were to stand up and feel their left testicle, 15% of them would feel that they have a varicose vein.
Yeah.
And most of them are fertile. Most of them are fertile.
And television general managers all over the country are very grateful that you didn't ask them to do that. You're saying that this palpation can reveal a varicocele condition?
Right. But what's happening is that most of the men who have a varicocele, the testicle isn't warmed up by it, and they remain fertile. And too many men are having varicocelectomy operations who don't have a varicocele.
Now, excuse me. I assume a varicocele diminishes blood supply.
No, what it does is it allows a lot of warm blood to drop down from the abdomen because the veins there are valves that allow blood to come back up into the body. When you stand up, the reason your whole body, all your blood doesn't just fall down to your toes is because there are these veins that prevent, one-way valves in the veins that prevent the blood from dropping down. Same thing is true with our testicles. This is part of our reproductive inefficiency, is that in 15% of all men, there is this varicose vein in the left testicle that allows blood to drop down and potentially warm up their left testicle and sometimes their whole scrotum so they're not making sperm adequately.
So the valve is not working then?
Yeah, the valve is gone. It's not working.
Now, did you say left testicle just to make the point, or is it more likely to be in the left testicle?
98% of the time, it's just in the left testicle.
They freeze sperm, right, before a vasectomy?
Well, no, most people don't. Most people don't freeze sperm before a vasectomy.
But you can.
You can, right.
Do they make a viable...
You mean for shelf life, yes.
Right, here's the problem with that approach. If a man has a sperm count of under 60 million, for reasons we don't know, his sperm doesn't freeze and thaw very well. So it's only good for 30% of men anyway. Second place, just think of how many specimens you would have to freeze if you're talking about a 15% chance per month of getting pregnant with artificial insemination. So that is not an adequate solution to the issue of vasectomy reversal. The issue is to do the vasectomy in such a way, perhaps, as to make reversal easier. So there's less pressure buildup, less likelihood of epididymal blowout.
And how do you do that?
If you leave the testicular side open so that you form a little sperm granuloma, you'll have less pressure buildup. Doctors are reluctant to do it because the lawyers are attacking them that they're not doing the vasectomy as well as they should. Doctors are so worried about lawsuits that they're doing vasectomies in such a way as to create greater pressure buildup and more epididymal blowouts, and therefore making reversal more difficult.
Excuse me now, let's just go over this one more time. So, all right, so if a guy decides to get a vasectomy and he's a little nervous,
yes,
and I assume most people really think a long time before this.
Right.
And he ought to, because the number of people requesting you and others to perform reversals grows every week.
Right.
Okay. You're saying that on the side of the vas that is clipped, the side closest to the testicle, leave a little nodule of something there? What?
Right. Leave that little side open instead of sealing it real tight. Now, 10 years ago or 15 years ago, more 15 years ago, that was done inadvertently. They would tie a little suture around it, and they didn't know how to do vasectomies that well, and it would leak without them realizing it and form a little nodule so there was less pressure buildup.
And those are easily reversed, you're saying?
Well, yes, because, well, not easily. It's never easy because you still have to do very delicate microsurgery to reconnect the vas properly so it doesn't scar down. But what's incredibly difficult to reverse is when the pressure buildup has caused blowouts in the ductwork closer to the testicle, which we call the epididymis. And to repair those blowouts are incredibly difficult to do.
But there's something disquieting about the possibility of a semi-opening near the testicle, which would allow the squigglies to maybe get back in the tube on the way to you know who.
And the solution to that is to do a
But is that possible?
That's possible. The solution to that is to seal the side going towards the ejaculatory duct much more thoroughly.
All right, you want to see that? Why don't we roll it? Let's see this film. This is a film of an act. This is a vasectomy reversal, is it not?
Right.
All right, then I assume we'll be seeing through the microscope.
Right. Now here we're sampling sperm from that vas. If that fluid shows good normal sperm, as you saw earlier in the show, then we know there's no epididymal blowout. See how we're sampling it through a tiny micropipette. This is all under...
What's the magnification here?
Magnification is 25x there. It's extremely high power microsurgical magnification. We're irrigating with a special solution. We're cauterizing these tiny little bleeders. These little blood vessels are about 1/1000th of an inch in diameter. And we're going to find that little lumen and we're going to put together the two cut ends of the vas after we've cut out the scar tissue that blocked it. Now this will be a successful case because we're going to reconnect it properly and because there was good sperm in the vas fluid. If we did not find good sperm in the vas fluid, then we have to go back to this more delicate structure, the epididymis, near the testicle, and we have to reconnect that. Now we've had 90% success with reconnecting the epididymis. With the vas, our success rate in terms of reconnection is over 99%. So you can see how important it is you have a 10% drop-off in success rate, even in our hands, and we probably have the most experience with microsurgery. We have a 10% drop-off in success if there are blowouts in the epididymis. Now here we're putting in those sutures. This stitch is about 1/1000th of an inch in diameter. It's invisible to the naked eye, and that's just the first of 6 stitches in the inner layer, the delicate lining of the vas.
You sew inward, outward.
Right, inside out, so that the knot is on the outside. If the knot were on the inside, the knot itself would block the flow of sperm.
And also, when you tighten the suture, you ensure the continued opening of the interior of the vas deferens.
That's right. We check it at every level like that to make sure that the suture didn't pick up the opposite wall and block it. Because that opening is so tiny. It's about 1/100th of an inch in diameter. It's smaller than a period on the end of a page.
And we'll be back with the author of How to Get Pregnant
microscope, not
in just a moment. I'm going to try something here. We've spent a lot of time talking about you and the woman and ovaries and fallopian tubes and all the rest, but let's not ignore the really impressive and complicated reproductive symphonic ensemble of the male here, and it really does. Can we see that? All right, there it is. Why don't you briefly tell us what's going on?
Right. It's really a complicated process, but the sperm are made in the testicle. And right on top of the testicle is this epididymis. And that makes it look very simple, but inside that little sausage is a 20-foot long tubule. 20 feet long, but it's all accordioned up into about 1 inch.
All right, if you dim the house lights a little bit so the audience can see the monitor, this is getting a little bit...
And
all right, go
the
ahead.
sperm go from this epididymis, which is a 20-foot long tubule, 1/1000th of an inch in wall thickness, into the vas deferens, and it goes up all the way into the abdomen, comes around the bladder, and enters into the ejaculatory duct, which goes through the prostate gland. Now, all this is sperm, very little volume, and the fluid that pushes the sperm out comes from the prostate and the seminal vesicle, and that's when you ejaculate the sperm out the penis. And the best portion of the sperm, therefore, as you can imagine, comes in the very beginning of the ejaculate. The first squirt has most of the good sperm.
Because what? Most of the good sperm are the ones that get to the goal line first? Is it like that?
Well, not really. The good sperm during foreplay, in a way, is important. There are studies in animals showing that the more foreplay prior to ejaculation, the more sperm is pumped up from the epididymis and the vas into this area here in front of the ejaculatory duct. Then at the moment of orgasm, then the ejaculatory duct, the seminal vesicles, squeeze the fluid out very powerfully, propulsively, and these muscles, called the bulbocavernosus muscles here, then squirt out under tremendous force. It would go out a good 1.5 to 2 feet, squirt it all out, but the vehicle that's pushing the sperm out, that's behind it, is the fluid that represents most of the ejaculate.
That's the vehicle for the sperm.
Right, it's pushing it out. Therefore, most of the good sperm is in the vanguard.
Okay. I don't understand. Where is the ejaculate manufactured? In the seminal vesicle or in the prostate?
Well, the prostate and the seminal vesicle, really.
Why do you need 2 of those to make the ejaculate?
Well, that's something we really don't know.
All right.
But we do know that the seminal vesicle squeezes it out through the ejaculatory duct into the middle of the prostate gland, and then from there, the muscles of your buttocks, which are the same. They're the same muscles that create orgasm in a woman, create orgasm in a man, and they squirt it out.
Okay, so it's a myth then to suggest that the woman is necessarily more complicated physiologically.
Oh, no, I think the man is extraordinarily complicated.
Yeah.
After vasectomy, what could be the cause of pain in the testicle during an erection?
Oh, well, vasectomies do create pressure buildup, and there are a certain small percentage of men that have pain from that pressure buildup.
What is the rate of infertility in a young male, say in his 20s, who had undescended testicles as either an infant or a child that were corrected?
It really depends. If it was corrected at a proper age, most of these men will have lower sperm counts than the population at large, but should have enough sperm to get the wife pregnant, but not all of them, and it depends on how well how properly the surgery is performed.
I've been taught that the egg is good for 24 hours, and you said only 8 hours. Could you clarify that?
Well, there's a lot of debate about that. I don't think anybody would say 24 hours. Some would stretch it to 12 hours, but that would be maximum.
Yes. Does the time of ovulation determine the sex of the child?
No, there have been a tremendous number of suggestions that it does, but it hasn't been verified by good studies.
If a woman has irregulation of ovulation or does not ovulate at all and is not interested in getting pregnant, is there any health problems for
Oh,
that?
yeah, she's at greater risk of cancer of the uterus unless that's treated later on in life.
Yes.
I understand they've found long-range complications on vasectomies.
No, I think we could discount most of those. The big population studies are showing now that vasectomy is safe.
Yes.
Is there...
Yep.
Does it...
The book is titled How to Get Pregnant. Its author Sherman J. Silber, MD.
I just wanted to know, for women who have to travel a lot on planes for business, one-day trips, or air stewardesses or whatever, does this affect ovulation or their biological clock?
The biological
Services
clock...
provided and promotional fees paid by the following.